Hocam başlayabiliriz.
So,
Buyurun.
Dear colleagues and friends, my name is Fuad Sanger and working in Germany. And my background is anesthesia and critical care, and it's a great honor for me to chair this session about the approach to bleeding and coagulopathy in trauma patients. And I would like to introduce my colleague and friend. And I would like to introduce my colleague and friend, Mark Megele, who is a trauma surgeon. I know him for many, many years, and he's not only a surgeon, he's also very active in science, and he's one of the surgeons who published also a couple of papers in the Lancet Oncology. And it's my great pleasure to hear and listen now to his talk. Mark, it's your turn now, please.
Yes, Igor, thank you so much for inviting me to this local meeting in Turkey. Right now, I think the weather is much better at your place now. When I look out of the window here, I can't see almost nothing because it's raining. It's a great pleasure. As Fuad already introduced me, I'm Mark Megele, and I'm a senior consultant of trauma and orthopedic surgery with the Cologne Mayhem Medical Center. I'm also head of research and of the Institute of Research and Operative Medicine, also affiliated with the University of Witten-Herdecke. So as we all know, uncontrolled bleeding obviously remains a major cause of death and trauma. And this has been repeatedly shown by several large-scale retrospective data analysis. And the last one was published back in 2017. Although due to the increasing awareness about bleeding disorders occurring after trauma, this trend is still evident. As you can see here, exsanguination still accounts for more than 30% of trauma death that occur within 48 hours after hospital admission. And what we also know is that death from exsanguination obviously occurs very quickly. And this has also been repeatedly shown. And the vast majority of patients that exsanguinate, they exsanguinate fast, usually within the first 4 to 6 hours, at median 1.65 hours. And what's also been shown quite recently was based on data from our National Trauma Database Registry, that about 1 out of 4 patients that we do see in our emergency department after having sustained a severe traumatic injury, these patients display laboratory signs of coagulopathy once they hit our ER doors, as evidenced by disturbances within their conventional coagulation assays. Coagulopathy also may develop over time, as you can see here on this nice slide. This is work from Greatest from the Netherlands, published in Critical Care 2011, that the percentage of patients with laboratory signs of coagulopathy may double within the first 24 hours after trauma. And this essentially means that although we see 30% of patients that do display laboratory signs of coagulopathy, this rate may increase within the later sequelae, and patients do become coagulopathic even after time. And there's a high need for continuous monitoring of these patients, since the rate may double or may substantially increase within the first 24 hours. And on the left-hand side, you actually see a patient that we treated quite recently in our emergency department. And as you can see here, the CT scan on admission, this patient had sustained a severe traumatic brain injury, shows a little bit of bleeding on the right temporal side of the CT scan. And if you look further down, the coagulation profile in this patient seemed or appeared to be quite normal, as evidenced by the ROTEM tracing and also by the conventional coagulation assays. But then we took the patient onto our observational unit, and within the later sequelae, this patient deteriorated, and we took the patient back to the CT scanner. And as you can see here on the CT scan, we obtained 3 hours after admission, there was a substantial increase in the intracranial bleeding, along with substantial signs of coagulopathy, as evidenced by ROTEM and conventional coagulation assays. And what's also been shown by by a subgroup of patients that were taken from the PROPA trial published in the Journal of Trauma and Critical Care 2019, this cohort consisted of a little bit more than 400 patients. But it clearly showed in those patients in whom hemostasis was achieved, every 15 minutes was associated with the decrease in time to hemostasis was associated with decreased 30-day mortality and also a substantial decrease in secondary complications and injuries. It's quite obvious that when it comes to severely bleeding trauma patients, that treat the bleeding is to stop the bleeding, so to prevent further blood loss and to prevent further states of hemorrhagic shock, but also to restore hemostasis. And obviously, treat the bleeding is to stop the bleeding, and what we can do surgically also already during the pre-hospital phase of care is to use compression and tamponades, also recommended as a clear 1A recommendation by the recently updated European Trauma Guideline. But what we also have learned from the military conflicts in Iraq and Afghanistan is to use pelvic binders and tourniquets, especially when it comes to severe internal bleedings into the retroperitoneal space in the context of severe pelvic injuries and fractures, but also the use of tourniquets has been quite shown to be very successful when it comes to severe bleeds from the extremities. And once the patient is admitted to the hospital, there's still the classical damage control and surgery approaches are being recommended in order not to do further harm in stopping the bleeding. And what we do here, we can see here is this can be achieved by pelvic packing and through the use of external fixators, with the overall aim to reduce the inner pelvic space, to introduce a counter pressure and to close the pelvic ring. I would like to briefly allude to you the European Trauma Guideline on the management of major bleeding and coagulopathy in its 5th edition. We are currently preparing the 6th edition that hopefully will come out next year. But the 2019 version is still valid. And one of the key messages of this guideline is that measures to monitor and support coagulation function are to be initiated as early as possible once the patient is admitted to the trauma bay. And obviously also the use of a goal-directed treatment strategy is now being advocated. And there has been much debate over the past which tests we can use to better estimate, to better diagnose, and to better guide our therapeutic approaches. And obviously, standard tests like the classical PT and INR test, these standard tests usually have long turnaround times. It's just an example from the Royal London Hospital, published by Ross Davenport in Critical Care 2012, that even in these advanced trauma centers within Central Europe, the turnaround times for standard coagulation assays can still be very long, even up to 80 minutes. And obviously, the classical standard coagulation assays, they provide only limited information on the quality and the dynamics of the clotting process, as they only assess a maximum of 4% of the entire thrombin generation. And what has been introduced as an alternative are these functional tests like TAG and ROTEM, where basically an ex vivo clotting process is initiated within the cup where a blood sample of the patient is put in, and then a coagulation activator is added, and the coagulation process is initiated. And once clot formation increases against the resistance against once the rotating cup in the context of a TAG analysis, or the rotating pin in the ROTEM test increases, and the level or the degree of resistance is then translated into a characteristical signal curve and shown displayed on the monitor. And these are the results of a typical ROTEM test, where basically by just looking at the curve, you can easily distinguish a normal clotting process within the cup. And this can be clearly separated from a delayed clotting that is potentially due or mostly due to a lack of coagulation factors, a reduced clot length, strength. This is usually related to a lack of fibrinogen or platelets, or last but not least to a hyperfibrinolytic pattern, where actually the clotting process is initiated, but the clot is not sustainable or breaks apart. And then this is followed then by a flat line in the ROTEM trace. And for me, these functional tests are currently very, very valuable in early detecting hemostatic disorders in bleeding trauma patients, as they can be used as point of care tests a bedside, either already in the emergency department or on the ICU, or in the operation theater. And these tests obviously produce very good information on the initiation of the clotting, on the dynamics of the clotting process, and obviously, as I alluded to previously, on the quality of the clotting as reflected by clot stability, firmness, and sustainability. And there has been much debate over the past on how to use these novel technologies in terms of treating bleeding trauma patients, and on how to use these specific results, on how these results can be translated into recommendations on how to more or less appropriately or more or less goal-directed therapies to bleeding trauma patients. And I would like to briefly refer to you to the 2014 consensus conference that was held in Philadelphia, where for the first time, based on the available literature, based on the clinical experience and on evidence, for the first time, specific TEG-ROTEM trace triggers and values were defined, which then can be used for clinical decision-making in terms of the more specific and goal-directed use of specific hemostatic therapies in terms of more appropriately using fibrinogen concentrate or clotting coagulation factor concentrates, FFP, platelet concentrates, and antifibrinolytics. And this briefly shows you a prospective pilot study that we conducted in context to our recently terminated Center TBI, Pan-European Center TBI studies on patients with a traumatic brain injury, where we essentially tested this algorithm and evaluated the feasibility of implementing such a protocol in centers, in trauma centers, initially naive to this technology. And this study was performed in 4 European trauma centers in Germany, Spain, Hungary, and Belgium. And the 32 patients could be enrolled and treated according to this algorithm. And the main outcome was defined as the adherence to the algorithm in the timing of the availability of test results, and this against conventional coagulation assays. In result, there was complete adherence to this algorithm in 20 out of 32 cases. And what has also been shown was that the tests, the ROTEM tests, were by far faster and quicker available for clinical decision-making as opposed to conventional coagulation assays. And this was statistically significant. And this was true for both the time interval between admission and the availability of first test results, but also for the interval between the blood sampling and the availability of test results. And on the right-hand side, you can also see how the adherence to this algorithm essentially translated into better clot quality, as the adherence to this algorithm was clearly associated with faster clot initiation, as reflected or shown by a decreased CT time, but also this was associated with better clot stability and firmness, as evidenced by the increased amplitude. And I would like to briefly take you to our setting, to our emergency setting in the Cologne Medical Center. This is a schematic outline of our emergency department, where we basically have the shock room, the resuscitation room in the center, where the patient arrives when the patient is admitted by helicopter. And around 10 meters away, we have what I would call a point of care room, where we basically have installed a fully automated viscoelastic testing device called the Rotem Sigma, where these tests are started within 5 minutes after patient arrival. And as you can see here in the middle, we can mirror this, the signal or the screen onto a large flat screen into the resuscitation room. And while working with the patient, we can see how the coagulation of the patient or the coagulopathy develops and behaves, and we can respond accordingly and activate our algorithms. And this is just a clinical example of a severely injured patient with a severe injury severity score of 43 points, with various injuries to different parts of the body: the liver, the thorax, the spine, the pelvic, the proximal femur, and to the brain. In the center of the slide, you can see serial Rotem traces beginning in the emergency room department, where basically the first Rotem showed almost a complete flat line. When you look at the FIBTEM trace, which is indicative for abscess of deficiency in fibrin polymerization. And this was then treated with a fibrinogen concentrate, 4 grams, along with the tranexamic acid. And this patient was then taken to the OR for damage control procedures. And the first intraoperative control showed an improvement in the FIBTEM amplitude. But on the other hand side, as you can see on the upper panel, that there was a slight prolongation in the initiation time of the clotting process. And then the patient was treated with PCC according to our protocol. The second intraoperative control then showed again a decrease in FIBTEM amplitude. So the patient received another fibrinogen concentrate 2 gram dose. And once we had it over the patient onto the ICU after having completed our damage control surgery interventions, the coagulation profile was almost completely restored. Today, there's quite a bunch of retrospective evidence that these strategies may be superior to the classical ratio-based approaches when it comes to bleeding trauma patients. This was shown by a retrospective comparison of viscoelastic testing, assay-guided concentration factor therapy based on data from Herbert Schöchel's Salzburg Trauma Registry versus a classical FFP ratio-based coagulation therapy. And there, for this cohort, we took data from our National Trauma Registry database. In result, there was no difference in mortality, but this was the study was not powered for. But we observed a significant difference in the use of allergenic blood products as evidenced for platelet concentrates, where essentially in 9 out of 10 patients, platelets could be completely avoided. And also this was true for the use of packed red blood cell concentrates, where basically 1 in 3 patients got through the overall procedure without any need of being transfused with red blood concentrates. This is another retrospective study we conducted also with our colleagues from Austria. This is a tight match pair analysis with the retrospective data. Again, patients that were captured in our National Trauma Registry database and being transfused with a ratio-based approach at first place. That these patients were compared with a more selectively and ROTEM-based guided strategy with the use of fibrinogen and PCC. And as you can see here, also the Austrian patients, they were less in need for allogenic blood products, and this translated into a strong signal towards less multi-organ failure in these patients. And this was statistically significant, despite the fact we only had or were able to include or match 18 versus 18 patients. So a very strong signal towards less secondary injuries along with the more targeted coagulation therapy at first place. One of the very few studies that actually up to date has assessed the use of a ROTEM-based algorithm prospectively was the RETIC study published by the Austrian colleagues around Dietmar Fries and Petra Innerhofer. These patients were adult patients with an ISS above 15, so traumatized injured patients with bleeding or at risk for hemorrhage. These patients were screened with a viscoelastic testing assay, with the ROTEM in this case. If they had a pathological ROTEM, these patients were randomized to either a treatment group that was treated with fresh frozen plasma according to the guidelines, and the other group was treated with coagulation factor concentrates, fibrinogen, PCC, and factor 13. And after each treatment cycle, these patients were reassessed for ROTEM. And if they had not recovered after the second treatment cycle, there was a crossover design, and these patients had to be converted into the other treatment arm. And what was very interesting to see that the rate of a conversion into the other alternative treatment arm was by much higher in the patients that were treated initially with FFP. So FFP treatment in about every second patient in this group was not effective. So after 2 cycles of treatment, these patients had to be converted into the coagulation factor arm. And this was only the case in 4% of patients that initially were treated with coagulation factors. And if you can also see here on this slide on the left panel that the rate of massive transfusion or the need of massive transfusion was substantially lower in those patients that were initially treated with the ROTEM treatment arm and coagulation factor concentrates. Why is you may have noticed that a major component within our treatment strategies lies on fibrinogen. And I would like to briefly allude to you why we think fibrinogen is so important. Fibrinogen is also considered as a coagulation factor 1. And no matter which coagulation model you take, might it be either the classical Y-shaped model of coagulation we all know from our medical textbooks, or the novel cell-based model of coagulation, as you can see outlined here. That the last and most essential step within both models is the conversion of fibrinogen into fibrin through activated factor 2A thrombin. And fibrinogen obviously is considered as the substrate for the clotting process, and fibrin is then cross-linked through activated factor 13 to form a stable clot. And what's also been shown quite frequently and is commonly accepted is that fibrinogen obviously is the first coagulation factor that reaches critical level in the context of severe bleedings. This may be true or may occur already during the pre-hospital phase of care, as outlined in the study from the Lyon group around Flocard and published in Injury 2012. The red bar is fibrinogen concentrate, and as you can see here, fibrinogen concentrate, this was a pre-hospital study, already drops substantially during the pre-hospital phase of care, and this as a function of injury severity. So the more injured the patient is, the more likely is the chance that the patient arrives in your trauma department already in fibrinogen depletion. And what's also been shown in the same year was that Claire Rook repeatedly showed in several works that low fibrinogen levels obviously are clearly related or have been uniformly associated to bad outcomes in these patients. And this was true for the 24-hour mortality and also for the 28 days mortality. And this is a result from a prospective multi-center randomized study we conducted in the context of our EU-funded European Trauma Network involving 6 major trauma centers across Europe. And what we found was that a median dose of 3.8 grams of fibrinogen supplemented to these bleeding trauma patients at the acute phase is able to increase clot stability as evidenced through the FIB10A CF5 test by 5.2 millimeter. And these 3.8 grams roughly correspond to what the European trauma guidelines suggest for early fibrinogen supplementation bleeding trauma patients, and that is 4 grams of fibrinogen. And this outlines you or illustrates to you based on electron microscopy findings published together with Dietmar Fries in British Journal of Anesthesia 2005. The effect of a supplemented fibrinogen to a diluted clot. So on the left panel, upper panel, you see a normal clotting under the electron microscope, then a diluted 30% with the 30% dilution. Where you can see that the normal fibrin network is destroyed or diluted, and once you add fibrinogen concentrate to this diluted clot, you see a restoration of the initial disturbed fibrin network. Very briefly, this was a pilot study where we assessed whether it would be feasible to administer fibrinogen concentrate already during the pre-hospital phase of care. This was a helicopter study involving 60 patients in different helicopter medical stations across Austria, Germany, and the Czech Republic. And this was a prospective randomized controlled trial where we assessed the early administration of fibrinogen concentrate during the pre-hospital phase of care to bleeding trauma patients, and the outcome was fibrin polymerization as evidenced by FIB10 MCF, so clot stability on emergency room arrival. And actually, this was a one of the very few studies where the primary endpoint was successfully reached. As you can see here, that those patients that did receive fibrinogen concentrate versus a placebo during the pre-hospital phase of care, these patients arrived with a much better clot stability in the emergency department, and this obviously was also related to less blood loss. And what we also observed, as you can see here on the right-hand side, is that we were able, through this early intervention during the pre-hospital phase of care, by the administration of fibrinogen, we were able to prevent this early drop of fibrinogen in these bleeding trauma patients, and the fibrinogen levels were kept within the reference ranges above 1.5 gram per deciliter throughout the entire study period. One brief word about the antifibrinolytic tranexamic acid, and since the CRASH-2 and the CRASH-3 trial, the 2 trial was related to trauma, the CRASH-3 trial was related to traumatic brain injury patients, showed a marginally beneficial effect with the use of an early tranexamic acid in bleeding trauma patients, both in polytrauma patients, but also in the TBI patients. And based on these study findings, there is still the strong recommendation to treat bleeding trauma patients as early as possible with tranexamic acid with a loading dose followed by an IV infusion. And this is still a 1A recommendation. And lots of emergency medical services across Central Europe have adopted this strategy and carry now tranexamic acid on their emergency and in helicopters and emergency vehicles for early pre-hospital administration. This is the result I would like to briefly allude to you to our ITACTIC study that was also conducted in the context of our pan-European trauma network involving 6 major trauma centers across Europe: Oslo, Copenhagen, Amsterdam, Oxford, London, and our center in Cologne. Within this network, we conducted a prospective multi-center randomized controlled trial and compared the hemostatic effect of an evidence-based VHA viscoelastic test guided strategy versus an optimized coagulation, conventional coagulation test guided transfusion algorithm in trauma hemorrhage. We were able to recruit almost 400 patients with clinical bleeding and activation of a massive transfusion protocol, and were able to randomize those patients into the 2 groups for a follow-up of 28 days. And the primary endpoint of the study was essentially the proportion of patients alive and free of massive transfusion after 24 hours. This is briefly the study outline. In the interest of time, I might skip this. At the very end, in the intention to treat analysis, we were not able to find a significant difference between those patients being treated with a conventional coagulation assay guided algorithm versus VHA tested algorithm. However, in the 2 pre-specified subgroups, in those patients that were coagulopathic on arrival and those with TBI, we saw a strong signal towards better survival at 19 days in favor of the VHA-based algorithms, and this trend became statistically significant for those patients that had sustained a traumatic brain injury. This is also a very nice literature review that was also published last year in the Journal of Trauma and Acute Care Surgery. This is basically the result of a very sound literature review that included literature between 1946 and June 2019 with an update in 2020. This analysis was based upon a PICO question, where basically it was assessed whether in adult trauma patients with ongoing hemorrhage or concern for coagulopathy, whether these patients should be treated with a TEC-ROTEM guided transfusion strategy versus a non-TEC-ROTEM guided transfusion strategy in order to reduce mortality, blood product transfusions, and need for additional hemostatic interventions. So this was the PICO question asked, and based on this PICO questions, there were 7 studies identified and that were taken into the further analysis. And here you can see the results with respect to patients transfused with the PEC red blood cell concentrates and with platelets. In both scenarios, there was a signal that favored the use of TEC-ROTEM in these bleeding trauma patients. And this shows you the results for the FFP units, also showing a signal in favor of use of TEC-ROTEM. And also a similar result was observed for mortality. So this led the authors, that was also translated into the practice guideline for the Eastern Association of Trauma in the US, where basically the authors came up to the conclusion to conditionally recommend the use of TEC-ROTEM versus non-TEC-ROTEM for adult trauma patient with ongoing hemorrhage or concern for coagulopathy to reduce blood product transfusion and mortality. And the reason, the rationale to make the authors these conditional recommendation was the potential benefit of fewer patients being exposed to blood products and reduced mortality combined with the lack of harm in those patients treated with TEC-ROTEM. The last study I would like to allude to you also published in 2020. This was a retrospective analysis of a large military database in the US, the Department of Defense registry, where basically military casualties over an 8-year period of time were included or analyzed, a total of more than 3,000 patients that were included into these analysis. There was a logistic regression implemented in this study in all adults, patients in need for blood products and viscoelastic testing, and this was then assessed for mortality. There was also propensity score matching done in these patients treated with viscoelastic testing assays versus non-viscoelastic testing assay-based patients. The patients that were essentially included in this study were a typical military cohort as opposed to a civilian cohort. Here we had almost 100% male patients, pretty young, substantially injured as reflected by an ISS of 19. And here also more than 80% penetrating in these patients. This cohort had a mortality of around 10%. In 80% of these patients, they had viscoelastic testing during the initial resuscitation, and after adjusting for confounders, and the use of viscoelastic testing in this cohort was independently associated with decreased mortality, and also a similar result was observed when looking at the results from propensity score analysis. And there was also a confirmed survival advantage with almost 60% reduction in all-over mortality for these patients in need for blood products. So this basically comes to the end of my talk, where basically I would like to present to you how modern coagulation therapy may be performed in the setting of bleeding trauma patients. And this basically shows you the so-called hybrid approach, where basically when the patient comes in extremis in your emergency department and may benefit from a volume therapy or needs volume, obviously a ratio-based approach using FFP, RBCs, and platelets in a ratio-based fashion. But as soon as the patient has stabilized, this strategy should be switched to a more or less goal-directed strategy based on a functional coagulation test like TAG ROTEM. And obviously, what's also what is self-speaking, that the conditions for coagulation to take place within the body, like correction of hypothermia, correction of acidosis, are self-speaking measures to support an adequate environment for adequate coagulation to take place. So this please allow at the very end a little personal comment on how trauma management essentially has changed over the recent years, according, or at least from my perspective. The upper panel on the left-hand side shows you essentially how trauma care was performed 10, 15 years ago, where we had a fragmentation of different steps in trauma care, consisting out of resuscitation, followed by damage control surgery, and then critical care. And all these different aspects are now being more or less integrated or incorporated into an integrated approach, where basically measures to support resuscitation and surgery basically are being performed together at the same time, based on results from real-time near-patient monitoring of physiological status and evolvement. And obviously the use or the introduction of viscoelastic testing is now being a key component for better individualized and goal-oriented therapeutic approaches in the overall sense of precision medicine, also entering the trauma arena. And with that, thank you again for inviting me to this meeting, and I'd be happy to take any questions if you have any. So Thank you so much, and looking forward to the discussion.
So, dear Mark, many thanks for this comprehensive and very clear presentation of the data. I think we are running completely out of the time. So we take this as a state-of-the-art lecture. So you have presented so many data, and this was very fun. And I think the most important thing what you impressed was you need a high level of fibrinogen on admission of the patient in the emergency room. You need a point of care testing like TAC or ROTEM, and you have to keep the patient high on high fibrinogen and use this with a tranexamic acid. I think this is the most important thing would take for them. And thank you very much again for your talk. Thank you very much. Okay.
Okay.
Bye-bye.
Thank you so much. Bye-bye.
Bye-bye.
Bye-bye.